Hello, good evening. Welcome to this evening. I will be going live with two top experts from leading fertility clinic Fitzrovia Fertility, based in central London, to talk all about PGT-A, what it means, the acronyms, how it can help with IVF success, and we will be answering your questions live as well. So please stay until the end. I'm being joined by Miss Shirin Kanjani, who is a consultant gynecologist and accredited subspecialist in reproductive medicine, as well as Mr. Dimitri Mavrelos, who is consultant in obstetrics, gynecology and reproductive medicine at Fitzrovia Fertility. So you'll hear from them about what PGT-A involves, who it is relevant for, and whether it can improve your success when having IVF. So we have Dimitri here. I will invite be with us any minute. Welcome everyone. It's lovely to see you this evening. Hello, and have your questions ready. We're exploring and discussing everything about PGT-A, what it means and how it may help you on your fertility journey. So I'm just welcoming them in now, and then we can get started. Hi everyone, nice to see you this evening. Welcome. We're just about to invite our experts this evening from Fitzrovia Fertility. If it doesn't connect, I will come back in a minute, but they are here, I can see them. Let's try again. Hello, welcome everyone. It's lovely to see you. Welcome. We're about to go live with Fitzrovia Fertility to discuss PGT-A and everything involved to enhance potentially your fertility treatment. Okay, bear with me. I'm just inviting them in now. I'd love to know where people are joining from. If you have any questions for our experts this evening, please don't be shy. We'd love to hear from you. Seem to be some issues with them joining. I will log out and log back in if so, but hopefully we can start in a second. I'm inviting lots of accounts. Here we go. Hello, good evening. Welcome. We're together. We're here.
Wonderful technology.
I
Lovely to
know.
see you, Eloise.
You too. Lovely to see you as well. I've just been giving you an introduction. Welcome, Dimitri. It's lovely to see you this evening as
Hi.
well.
Hi, good evening.
And here we are. We're all together, and we're going to be discussing PGT-A. And I've invited people to share their questions as we're talking. So, first of all, following my introduction, please could you introduce yourselves, a little bit about Fitzrovia Fertility, and then let's discuss whether PGT-A testing is relevant for patients, who it's relevant for, what it entails, and how it may help with success rates.
Do you want to go
Great.
first, Dimitri?
No, you go ahead, obviously.
Thank you, Eloise. Thanks for having us. So my name is Shirin Kanjani. I'm a consultant gynecologist and I have a subspecialist accreditation training in reproductive medicine and surgery. I have been a consultant at University College London Hospital for the past 8 years. And together with Dimitri, we founded Fitzrovia Fertility in order to be able to sort of provide very evidence-based care. We both have very scientific backgrounds, but also a very individualized care to our patients.
Wonderful.
Hi, I'm Dimitri Mavrelos. I'm also a consultant in reproductive medicine also accredited by the Royal College to provide reproductive medicine care. I have a substantive NHS job at UCLH, and for the last 10, 15 years, I've spent a lot of time talking with couples and women who are struggling to conceive, or also who've had recurrent pregnancy loss. Yeah, and I'm very happy to talk about PGT-A and how it can or may not be appropriate for people.
First of all, for someone who is new to a fertility journey and perhaps exploring IVF, could you please explain what PGT-A means and what it is?
All right. Well, I'll take that. Shall we take
You
it in
go first.
turns,
Yeah, I'll
Dimitri?
take it in turns. Yeah, and then yeah.
So, well, PGT-A stands for pre-implantation genetic testing for aneuploidy. Now, it's quite a lot of big words in there, but basically what it does is when embryos are created through IVF, they will have half of the chromosomes, and chromosomes are these packages that carry our genetic material, right? So the embryo has half of the chromosome from the mother side and half of the chromosome from the paternal or the father side, and then it comes together. A normal embryo should have 46 chromosomes. Like I said, 23 from the egg and 23 from the sperm. The embryos will develop to a blastocyst stage. In PGT-A, we can take a few cells from the outer layers of the embryo and send it for genetic analysis. And this will help us find embryos that are more likely to result in a healthy pregnancy. And we can basically prioritize which embryo transfer first and also hopefully reduce the risk of miscarriage or failed implantation.
Yeah. So I usually say, we all carry around 23 pairs of chromosomes. And really, if you have extra of something or missing one, most of the time it's either a negative pregnancy test or a pregnancy loss. The only chromosomal abnormalities that survive and can give an ongoing pregnancy and a child are Down syndrome, which is extra chromosome 21, which happens to be the smallest chromosome, and then some others, chromosome 13 and 18, and also some sex, like missing a chromosome X or an additional Y, and so on. So, yeah. So I shouldn't say PGT-A is about screening embryos and finding ones that have correct combination of chromosomes.
I think sometimes, I don't know if you see this with patients, but there can be misinformation that PGT-A somehow improves your embryos. Of course, it doesn't. It just improves your selection process, right? In order to be able to hopefully get
Yeah,
a healthy pregnancy in a shorter space of time.
that's exactly right. I think you have to be very clear. And the challenge with PGT-A is that what I usually try to do is lay out the facts, and then people can choose whether they do it or not. PGT-A is not going to increase your overall chance of taking a baby home out of a bunch of embryos you created, because it really is just about selecting embryos. You can select embryos by the womb and see if they implant or become a pregnancy loss, or you can select embryos by doing a biopsy and finding out which one is chromosomally normal and put it back inside the womb in simple terms. And we can explore the kind of more nuanced aspects of that.
There are obviously lots of acronyms flying around the fertility space. Would you be able to explain what some of them are when it comes to embryo testing, and how they differ from one another?
So I'll take this one. So PGT-A, like I said, is pre-implantation genetic testing for aneuploidy. Aneuploidy basically means the number of chromosomes. Do you have an extra copy? Do you have one less copy? Do you have a few extra copies? That is just looking at the number of chromosomes, right? Which, like we said, can help with identifying the best embryos for transfer. Like Dimitri said, shortening time to pregnancy, right? For a lot of couples, that's important. Do you want to shorten time to pregnancy? Another one is called PGT-M. PGT-M is testing for known genetic conditions. So, for instance, at Fitzrovia Fertility, we offer couples career match screening, right? So both couples have a blood test with genetic testing, and we look at the genetic conditions that they may carry as carriers. That doesn't impact them. But do these come together at some point that may result in an affected child? right? Or is there a history, more commonly, is there a family history of genetic conditions? Is there a genetic condition that one or the other of the partner have that they would wish to screen for the child to not have be affected? A very clear example of it is the BRCA gene now that we are selecting
Yes.
for very often because women have had family histories of BRCA gene or have BRCA gene, or men, and you want to try to create embryos that don't have the BRCA gene. So it's a known gene, and both partners have to have specific genetic tests, usually a swab in the mouth. Their genetic sort of profile will be mapped into that specific gene that is affected, and then the PGT-M will sort of look specifically at that gene. And then there's the PGT-SR, where there is structural changes in the chromosomes. So one jumps and sits on the other one and vice versa. And that again is if that particular, for instance, balanced translocations in the genetic material is being identified in one or the other partner. And then you can look at that in more detail. So you will need background information or a background diagnosis, so to speak, on either side to do the others.
Yeah.
And at Fitzrovia Fertility, would you routinely recommend that a patient screens embryos, or is this something that is for select patients dependent on their situation?
I think, Eloise, that's always a discussion because in my experience, presented with the same facts, couples will make completely different choices and have completely different objectives. I think you can say that if out of a bunch of embryos you want to get the maximum chance of pregnancy, then probably testing the embryos is not the right thing because testing the embryos requires them to be biopsied. And yes, biopsy is very safe, and most embryos by far survive that process, but some may not. And then you've lost an embryo that could have given you a pregnancy. So if you want out of your embryos to have the maximum chance of pregnancy, then probably transfer every single one. But if you want to get to pregnancy faster, you want to avoid negative pregnancy losses, you want to avoid negative pregnancy tests, pregnancy losses, then I would suggest you test your embryos. And in practice, testing embryos, I think, becomes more attractive the older the woman is, because then as you get a little older, the chances of having more abnormal embryos in a bunch goes up. At, say, under 35, just naturally, about 40% embryos will be chromosomally normal. At 42, you'll be closer to 1 in 10. And so,
And I would presume that women of that age may have fewer embryos as well.
well, exactly. I think the ideal patient for me, and Shirin will give her opinion, but for me, the ideal patient for PGT-A is a patient at 40 who has high reserve. And admittedly, that's relatively rare, but it's not as rare as one you may expect. And in that patient, PGT-A has a clear indication. For me, I deal with a lot of couples with recurrent pregnancy loss. And I always keep in mind that recurrent pregnancy loss has massive physical impact, has huge psychological impact as well. And in that context, people may, accept that testing embryos reduces their cumulative chance, but really want to make everything possible to reduce the risk of another pregnancy loss. Also, the other thing to say is that because pregnancy loss is so multifactorial, sometimes you need to start isolating factors and say, okay, well, we want to make sure that the embryo is chromosomally normal, and then we can think about all these other relatively minor things that in some minority patients play a role. But these are the difficult cases that we end up seeing and hopefully helping, where there's lots of factors to consider.
I presume it must be frustrating for you both, or doctors, fertility experts, as well as for patients and embryologists, when an embryo is transferred that's been tested and is looking good and it doesn't work. Does that often happen? And where do you go for next steps after that?
So exactly, that's quite a frustrating situation to be in. Our rates with transfer of a PGT-A euploid normal embryo at Fitzrovia is about 62 to 63% chance of live birth.
That's
So
amazing.
yes, you're definitely staying on the higher side of the sort of 50-50 statistics, but you still have 37-38% of the
Yeah.
patients that don't fall pregnant with the first transfer. Now, I think Dimitri and I both are a big fan of a study that was published a few years ago that showed actually if you transfer 3 consecutive embryo transfers of chromosomally normal embryos, you have on the upside of 90% chance of a live birth. So sometimes the message here is actually not at every cycle you will be lucky in that the endometrium is optimal. Not every embryo that is normal has the right kind of energy that comes from the mitochondria, right? And not at every sort of preparation time your immunology might be in sync. But if you bear with it with 3 transfers, you have a really good chance of live birth. So I personally speak for myself. I try not to get too overwhelmed with one negative transfer of a euploid embryo, provided we have another couple in storage. And my temptation usually, and the way I like to guide my patients is to keep calm and carry on. Obviously, unless there is something else glaringly obvious, right? We would have by this point made sure there is no polyps in the endometrial lining. There is, for instance, no hydrosalpinx. There is no sort of anatomical problems. So we would have crossed all the T's and dotted all the I's in terms of the things that we could have checked. But usually, I think, in my experience of having done this for a while, actually keeping calm and carrying on does result in that cumulative live birth rate of more than 90% in the absence of any other glaringly obvious abnormalities.
And the evidence supports that, right? Because, you know, in those studies, 4,500 embryo transfers, transfer one, 60% took a baby home, but then, you know, 40% didn't. Second transfer, another 20% took a baby home, and then third transfer, another 10%. The challenge, Eloise, I think, and that's something we face in the clinic, is that, okay, well, you've had a euploid transfer and you didn't get pregnant. Shall we now go through a whole process of testing your endometrium, doing your Emma, your Alice, your immunology, all of those things that add, you know, discomfort to the woman, time to pregnancy, and cost?
Yeah.
When actually a significant proportion of people will get pregnant next cycle. And I think it comes down to the availability of embryos. If these embryos are from frozen eggs from 5 years ago that you're never going to get back, then you have to be super conservative. But if, you know, these embryos, I mean, nobody wants to be wasteful with embryos, but if you've got availability of embryos and you can make them again if it turns out that there was something else going on, then maybe you go for a second or even a third transfer. It's not an easy choice to make, but I have to say endometrial testing is also not a fantastically accurate aspect. It sometimes gives useful results. So that's the balance we have to strike in every clinic appointment, unfortunately.
That was my next question, actually, regarding results. How do you explain these to patients in terms of what you're seeing from the embryos and then, you know, I guess, the embryologist's advice when it comes to selection and transfer?
So I'll take this because it also includes a really good announcement in that we've partnered up with a fantastic geneticist called Sarah Lavine, who's joined us, because I think it is really important to admit that neither Dimitri nor I, nor any other consultant fertility specialist is also a geneticist, right? And that's something that needs to be sort of acknowledged. So when the results come back, sometimes the results are very straightforward in a way that we've tested 7 embryos. There are 4 completely euploid or normal embryos. So euploid means that the correct number of chromosomes. So that's kind of, we have a look and we think, okay, so I can make a phone call to this patient, and obviously the embryologist has already sort of shared the details usually to a degree. So we usually ask the couples, do you want the embryologist to send you your results ahead of your consultation, or would you like us to hold on to everything and have a discussion? And I would say 95% of the couples say, can we have the results and then we can discuss together. So we share a screen and go through results, and or, you know, bring it up in clinic and go through the results. And we say, okay, euploid embryos, 60 to 63% chance of live birth. Fantastic. There's other 2 options. You can have either mosaic embryos, which means some cells in the embryo are normal and some are abnormal. Now, if you think about it, there are degrees to mosaicism. Are a large percentage of the cells normal, or a large percentage of the cells abnormal? And what are these abnormalities, right? And this is where I think it is really important to bring a geneticist into the conversation, to have a detailed discussion with the couple. Now, we transfer mosaic embryos after discussion with the couple, because actually most of the studies that looked at mosaic embryos suggests that these embryos can result in healthy live births because the embryo has the ability to repair itself, right? And these cells are taken from where the placenta would have been formed, not from where the actual fetus is going to be. But I think it is important to understand and realize one's limitations and bring in exact experts into these discussions. The other outcome would be that you will have a completely abnormal embryo, and we will discuss with the patients that an abnormal embryo, all the studies show, doesn't result in a live birth rate, can result in a miscarriage, and the advice there is to discard those embryos, but with consent from the couple.
Yeah.
Makes complete sense.
I think the study I usually quote in this, and I think it reassures me, is a non-selection study where people basically took 400 embryos, biopsied them, put those results in a drawer, went ahead with transferring those embryos, and then looked back. And reassuringly, the embryos that were labeled chromosomally abnormal in that study never gave live birth, which
Right.
reassures me. Of course, look, there are other studies out there where an embryo was labeled chromosomally abnormal and there was live birth. And of course, there's various steps in the process. There's the biopsy, there's the lab that analyzes, and so on.
Yeah.
But in the most, I feel reassured that when an embryo is labeled chromosomally abnormal, its potential is zero or very close to zero, which is important because the history of PGT-A was the previous iteration of PGT-A was day 3 biopsy, and that clearly actually was harmful to patients. So and it went out the window very quickly, thankfully, because there were the evidence in the trials to show that. But I think day 5, day 6 biopsy, there's enough evidence to support it. And of course, the other thing I usually say, Eloise, is that we are at the forefront. Right now, this discussion is at the cusp of what is known about human fertility and human embryos. And, when you speak with Sarah, there may be single gene mutations that are not going to be picked up on a chromosome analysis that also contribute. Because why does a chromosomally normal embryo miscarry? Frustrates me no end. Everything looks normal, normal embryo, good progesterone, good endometrium, 8 implants. It gets to 6, 8 weeks, pregnancy loss. Why?
Yeah. Yeah.
Nobody knows that answer. So
And
that's for us to find out.
do you think AI will enhance or be part of this testing process in the future?
I think that's a really good question. I will take it first, and then we can share our thoughts. So I think AI has actually been a part of fertility and embryology for a very long time. We've got this very very clever microscope with with lots of algorithm in it, called an embryoscope, right? So that's AI that has been trying really hard to help embryologists select an embryo. And to the best of my knowledge, the correlation of how good an embryo looks and if it is chromosomally normal is not there, right? What is kind of at the forefront of research now is trying to find non-invasive ways to find a normal embryo, right? And in fact, I was part of a study at Imperial College when I was doing my PhD that we looked at the fluid around the embryo, and we were looking to see if there is any of the secretions of the embryo into the embryo culture that you could actually test and find a biomarker that would correlate with the euploidy of the embryo. There are lots of studies worldwide that is looking at all the secretions of an embryo in a culture plate to try to see if they can correlate it. And frankly, I won't be surprised if within the next decade we have a non-invasive way of figuring out the chromosomal content of an embryo, but we are not there yet. PGT-A, the biopsy, at the moment is the most evidence-based, best available tool we have.
Yeah,
Fascinating.
no, I agree with that. I think AI, in terms of analyzing the videos of embryo development, hasn't shown that it can substitute PGT-A, although also we should acknowledge that when you have a bunch of normal embryos, those that look better tend to do better in terms of implantation. The
Yes.
morphological criteria do play a role. There is value, and that's value that's beyond the chromosome content. It's in addition to. But yes, for embryo selection at the moment, biopsy and PGT-A seems to be the best approach.
That's really interesting to hear. The HFEA, they have a traffic light system and a
Yeah.
red rating for PGT-A. Could you explain what that means and how patients, what they can take away from that when having a discussion with you, for example,
Yeah,
about
no,
whether
I'll
it's the
take
right
that.
fit?
I think that that's interesting. It depends on what the question you're trying to answer with PGT-A is, because the HFA
Mhm.
also have it green for miscarriage, right?
Right.
So if you think, as you said in the beginning, PGT-A is not going to increase your chance of having a baby out of a bunch of embryos. It's just not. Because instead of biopsying them, exposing them to that risk, albeit small, you could just transfer them and your cumulative chance will be
Yeah.
better or the same. At best, PGT-A is going to do the same thing as transferring all the embryos. But if your aim is to select the embryo and reduce your risk of miscarriage, then I think PGT-A has a role. I'm afraid, and I'm happy to tell the HFEA too, giving a three-color system to try and summarize what me and Shirin and a whole bunch of other people have whole conferences for is a little bit, you know,
Simplicity.
difficult. It's simplistic, right? Because
Yes. Yes.
there's nuance to all of these
Of
discussions.
course. Of course.
So that's what I would say to the traffic
Hmm.
light system.
Hmm.
I wouldn't do routinely PGT-A. I mean, the States, they do 95% of cycles have PGT-A. And I think that's so probably a bit excessive. It's not one size fit all, and some people don't need it. If you have one embryo, why would you test it?
Yeah. Yeah.
Well, I tell you why you would test it. Because to be fair, I've had patients who've had Down syndrome pregnancies, and then they are faced with a very difficult choice, and they don't want to be exposed to that risk, right?
Hmm.
So
But those are the extremes, right? What is
Of
really
course.
important here is the nuances, right? So I think the HFEA, very well intentioned, wants to try to guide patients through really challenging choices, right? Because for Dimitri and I, we sit here, we've gone through all the literature, we live and breathe this, and still there are sometimes maybe things that we don't agree on, right? So for patients to be faced with those choices, I think that's really challenging. So
Mm.
I think they rate HFEA race treatments, the add-ons, based on the strength of the evidence, right? But if something is red, it also means that the evidence is mixed. And I think more importantly, the benefits depends on the nuanced situation, which means, like Dimitri said, we would never offer everyone PGT-A. I think, when you have young women who are going through treatment, the diagnosis is male factor. You kind of think, okay, well, there's absolutely no indication here, and frankly, first do no harm, right? So if there's no indication there, you will stay off it. But you also have women who've had, like Dimitri said, multiple recurrent pregnancy losses. The sheer idea of having to go through another miscarriage is unbearable, right? So in that case, you will of course offer PGT-A. So it's very nuanced, and I spoke about two very extremes. There's a lot of in between that you need to really. Our job is lovely in a way that you can give all the information, you can empower the couple, the patient, to make a decision. But at the end of the day, it is a decision that comes from the couple based on all the
yeah,
information you give them and you guide them.
Yeah,
yeah.
absolutely. And what if a patient's embryos don't make it to blastocyst?
Well, would they ever make it to blastocyst is the question, right? So I am of the camp that if an embryo is not going to make it to blastocyst in culture, it's not going to make it to blastocyst in utero. I don't think that there is a difference in putting an embryo in utero than keeping it in culture. So if the embryo doesn't make it to blastocyst, um, then it would have never given pregnancy in my thinking. I think it's an excellent question because the studies that have looked at PGT-A have um, obviously PGT-A can only be compared when you have embryos to biopsy. So there are patients who will never have an embryo to biopsy, and
Hmm.
those are
Hmm.
excluded from the eventual outcomes. But if they have no embryo to biopsy, then they have no embryo to transfer. So I also don't see that as a big issue.
So, like you alluded to before, Dimitri, the issue with PGT-A and a non-blastocyst will propose the risk of you deciding to test an embryo on day 3 if you want to do PGT-A. And we know the testing in day 3 is completely inaccurate, right? You will discard good quality embryos.
Yeah,
You will.
exactly.
It's a complete no go, right? Because
Mm.
the evidence is very, very behind that. So if you are going to do a day 3 transfer, it won't be at Fitzrovia at least, and I think in most of the UK clinics, it
Yes.
won't be a
It
genetically
won't be a
tested
genetically
embryo.
tested embryo.
We can
Yeah.
make a decision that actually, okay, you want to give the embryo the best chance, and this is usually in women who've had multiple failed cycles, want to do it as a final attempt, so that's possible, but it won't be PGT-A embryos because it's just
Yeah.
the
It
evidence isn't
cannot
there
be.
to back it up.
Absolutely. And timelines, what does that look like for patients? How long does PGT-A testing take?
I think that's a good one actually, because you can argue there's an economic argument as well to it, which is, ultimately, if you are going to end up having a whole bunch of transfers that didn't work out or pregnancy losses, there is a cost to that. If you are having an embryo transfer with a maximum chance of pregnancy, that is potentially a saving. But it does mean that you do not have a fresh transfer. You have to wait 2 weeks for 3 weeks for the result to come back, and then you're committed to a frozen transfer. And you could have, by chance, come across the euploid embryo on your fresh transfer. And that's why,
Yes.
younger people who have a good proportion of normal embryos, who've never had pregnancy loss in their history, maybe they just go for a fresh transfer. Sometimes what I do is have a fresh transfer if you have a good background chance, test the rest. Because then if you're not successful, you can come back to a tested embryo and you have an even better chance of having a baby. So
And what does the data say in terms of fresh versus frozen transfers now and success?
I mean, I think they're equivalent. The worry in the past was that survival of embryos was not very good. So, freezing embryos was a risk. So people didn't want to take that. They wanted a fresh transfer. But now survival of embryos is excellent. There are subgroups of patients where I would advocate a frozen transfer. Certainly, adenomyosis is something close to my heart. We've published studies on this, and there is suggestion that frozen transfer with prolonged downregulation gives better outcomes. And we're doing the only randomized trial in the world at the moment.
Wow.
And also endometriosis. Again, we were looking at the meta-analysis, and perhaps there's an advantage to freezing embryos and doing a frozen transfer.
Well, their data is a little bit biased, obviously, Dimitri, now, because sometimes with frozen transfer, many clinics have higher success rates, but that's not particularly because it's a frozen transfer. It's because it's a frozen transfer because it's a PGT-A embryo. You
Right.
have a higher chance of success, right? So
Right.
if in untested embryos, most of the data suggests that they're neck and neck, potentially a little bit higher in a frozen group, like Dimitri said, owing to the fact that there's a subgroup of patients with endometriosis and adenomyosis that do better in a frozen cycle. But the data would eventually be skewed for frozen transfer outcome because you can only really do a frozen transfer for PGT-A embryos.
And also, if you have a frozen embryo that survived, you've selected embryos, right? So it could
Yes.
be that there was an embryo that would not have survived the freezing thawing because it wasn't a very competent embryo, but it did. So you've already applied the selection pressure by freezing them.
Fascinating. I know, knowing the team at Fitzrovia Fertility, just how holistic you are in your care. And so I know the answer is going to be yes here, but could you tell us a bit about the emotional support that your patients see as well when they're going through fertility journey with you, and also with, getting results of PGT-A screening, for example, and next steps in their journey following this?
Yes, Eloise, you know that the support at every level is at the core of Fitzrovia, right? So, like I said, we go as far as discussing with our patients at the start, how do you want to be told with your results? Because they develop a really good relationship with their consultant, with their fertility coach, with their nurse. Would you like one of us to contact you? Would you like to hear from the embryologist in the labs? Would you like to discuss it at your appointment? So we preempt the possibility of how you get your results, right? So that's the first sort of important part of the puzzle. Then, like, we have a fertility coach for every patient. So they will be in contact with their coach if they have any questions or concerns. And then they will have an appointment with their consultant. And all our patients get counseling with Linda, our fantastic counselor, should they wish to. It's not compulsory, but most people take it up. So we have this sort of network of support around our patients. But I also, and like I said, recently we have started working very closely with Sarah Levine, our genetic counselor, because I also think the level of scientific expertise in these discussions is equally as important. When we said Fitzrovia Optimish and I were very clear about this being a very scientific, very evidence-based, and yet holistic setup. So I think, all the soft support is very important, but also the scientific, high-end, latest research support is equally as important.
Yeah, I mean, look, what I find is that couples that come to us, it takes time, right? To do from first consultation to doing a cycle to getting results to doing a frozen transfer to having a baby may take, I think, at least 6 months, maybe a year sometimes, and sometimes couples will be with us 2 years, and we are we have to be embedded and part of that journey. It's the only way that it works. We have to be part of helping that couple have a family or that woman, and that's how we operate. And that then translates into all the support that we put together because we are all the team is invested in our patient's outcome. And that's why we do this job, right? I mean, it's at the core of our job, and to be honest, it's enormous personal satisfaction when it comes to fruition. It gives us is that dopamine hit you get when you get a message and you're like, oh baby, and it's just makes your day worthwhile, right? So
Of course.
But also,
Well,
Elvis, I don't know if in your talking points you were coming to the limitations of PGT-A, were you?
please cover it. Please, I'd
Right.
love to hear more.
Because I think it's also really important, right? We are saying that there's this technique that identifies
Yes.
embryos, and that's all true and that's all good. But I also have many patients coming to us and we discuss PGT-A and they say, okay, so I'm not going to have a children that might have a genetic condition. And I think that myth really needs to be bust here because
Right.
that's not true. PGT-A, like we said, only looks at the number of chromosomes. Each chromosome packages your genetic material. So PGT-A does not mean you're not going to have a child that has no genetic condition. And that is so important because so many couples are under that sort of misimpression of ability of this test that it doesn't frankly carry. So again, I think for us it's really important to have a wraparound genetic package. So when the couples ask that question, like Dimitri said, in the States, I think you're very familiar with treatment in the States and the clinics there, but 90% of the couples take up the carrier match screening. So both couples have their genetic material looked at. Is there a crossover that might result in an affected child? The risk might be low, but the burden of that risk can be very, very high, right? So that's the first step. Do we check carrier match? Then you do the PGT-A, the number of chromosomes, and then we can do non-invasive prenatal testing. In the past, the NIPT or the Harmony, or it's got lots of different ways. You do a blood draw, you check the baby's blood cells in the maternal blood, and look to see if it's got any chromosomal abnormalities. And they normally look at chromosomes 13, 18, and 21, right? Down syndrome, and the other two are not compatible with life. But now we have extended NIPT panels. We've got panels of non-invasive prenatal testing that can actually look at the genetic making of that fetus, right? Again, it's really important. Not everyone should have it, but if people are under the impression that the PGT-A will look at all the genetics of their child, it's important that they're told that it doesn't do that. But there are other tests available that with a genetic counselor, they can sort of explore those options too. So I think, it's an amazing test, but it's got certain limitations as well.
Great point. We haven't actually discussed donor, so egg donor, sperm donor. Does this make a difference to your suggestion when it comes to PGT-A?
I mean, egg donation is usually for younger people. So, in the same context, I wouldn't advocate PGT-A under 35 routinely. I don't think it's necessary. Sperm donor, that's a good question. I mean, we did do back in the day a little study where we looked at guys with higher sperm DNA fragmentation and the proportion of chromosomally normal embryos in age-matched partners, and there seemed to be a trend. So I suppose, but then you wouldn't necessarily know the sperm DNA fragmentation of a donor.
Mm-hmm.
Again, I suppose sperm donors are younger men with good quality sperm. So I suppose, again, I don't see the utility of PGT-A in that context.
No, I agree. I think it usually, when it comes to male fertility, there is also an impact on the quality of the embryo. But in terms of the PGT-A results, I think most studies are supporting the very strong link with female age more than anything else.
Yeah.
So I think with the sperm donor, I don't think that's an option you will go to try to get more normal embryos. But for sure, you will go to a younger egg donor in terms of maximizing your chances of having a chromosomally normal embryo.
Yeah, that makes complete sense. Is there anything else that you think would be worthwhile covering on the topic of PGT-A?
I think, the question about risk to the embryos, I think is important. And also the developmental competence of embryos that have been biopsied. And on both of those counts, look, I'm a surgeon and I know that, when you operate, people have different levels of skill. And I would ask that question of the embryologist. And in fact, I referred a couple to the embryologist just the other day and say, look, okay, well, what are your lab success rates of survival for these embryos? And don't be afraid to ask that question. I think it's fundamental, and labs will be happy to answer that question because they look at those things. And given that, the evidence again shows that embryos that have been biopsied don't seem to have worse outcomes in terms of implantation and so on. So I'm reassured that that's good.
That's really useful to hear. Shirin, do you have anything to add?
Yeah, I agree. And the survival after thaw, right? There is always that, you thaw and freeze, and there's always a risk to embryos of survival after freeze thaw. Now, you may well argue that an embryo that doesn't survive a freeze thaw may not have survived the process of implantation, and that's a way of screening on its own, but that's also really important. And I think that takes us back to the beginning of the conversation where we said, PGT-A is usually a better selection for people who have the luxury of actually being able to sort of select from a pool of embryos, So ideally, you're not going to put two embryos through the test unless, a female age is such and you want to reduce the risks of miscarriage to a degree. So, if you can afford to sort of lose an embryo out of a large pool of embryos, you kind of can sort of consider the risks to the embryo minimal. But those risks need to be considered. I agree.
Well, it's fantastic to hear everything tonight. Thank you so much. And also about the genetic side, the support you have there, which is also wonderful to hear. I've experienced coming into the clinic multiple times and know the team well. And for anyone who is looking for expert guidance and wants first, second, third, whatever it might be, opinion, I strongly suggest that you come and chat with the team at Fitzrovia Fertility. We've linked up your details in the bio, so please do check out their website and pick up the phone because, as you can see, a wealth of experience and very, very happy to discuss personal situations and tailored advice. So thank you very much for your time this evening. It's a pleasure chatting with you. And yes, learned a lot. So thank you.
Thanks
Good
for
to see
having
you.
us, Eloise.
Thank
Have
you,
a good
everyone.
evening, everyone.
Bye, everybody.
Thank you. Bye-bye.
Bye-bye.
Bye.
Bye.